Greetings and a warm welcome to all thinkers present here. I'm Shwastika from Team Clearnet, serving as the allocated session assistant to ensure a seamless experience. Clearnet is India's most trusted and widely used digital platform, offering a multitude of engineering services exclusively for the doctors. Clearnet is delighted to be chosen as the digital partner for this event, jointly organized by Karnataka chapter of IACTA, Indian Association of Cardiovascular Thoracic Surgeons, Indian College of Anesthesiologists, Global Intensive Care Symposium, International Society of Cardiac Ultrasound, and Global Healthcare Foundation. So today's focus would be the Comprehensive Echocardiographic Examination TEE. Now we are going to start with the welcome video. And now I would like to invite Dr. Muralidhar Kanji sir to take over. Over to you, sir.
Good morning and welcome to the Sunday breakfast session. This is being jointly hosted by the Karnataka chapter of IACTA, the Indian Association of Cardiothoracic Surgeons, Indian College of Anesthesiology, Global Intensive Care Symposium, Global Heart Care Foundation, and the International Society for Cardiac Ultrasound. As you are aware, this program is being conducted on every Sunday to benefit the interested candidates, and usually comprises of online lectures with experts with useful interaction at the end of each talk. Today, the subject of discussion will be comprehensive transesophageal echocardiographic examination. And we have three experts with us today. Dr. Nagaraj from the Abu Dhabi, Dr. Prabhakar from Bangalore, and Dr. Rupa Sreedhar from Trivandrum. All of them are extremely experienced as well as knowledgeable, and we look forward to having a great interaction with them. Before I hand over the podium to the faculty of today, I request you to post your questions or comments in the chat box and we will answer them at the end. And if you want to talk to the faculty at the end, please unmute your mic and you will be able to talk to them straight away to ask your question or comment. With that, I request Dr. Rupa Sreedhar and Dr. Prabhakar to take over. Thank you.
Can I speak, sir?
Yes.
Yes, ma'am. Yes.
Yeah. Knowing the acquisition of standard and additional transesophageal echocardiography views using the correct angle, sector depth, and probe adjustments, recognizing the structure seen in these views, and knowing the diagnostic uses of each of these views is a basic step in mastering transesophageal echo. Now, we have three guidelines. Rebecca T. Han et al. Published Guidelines for Performing Comprehensive TE in the Journal of American Society of Echocardiography in the year 2013. Kanchi Muralidhar sir et al. Have published the recommendations of our own IACTA for the practice guidelines for perioperative TE in the Annals of Cardiac Anesthesia in 2013. The Indian cardiologists have come out with the Indian Academy of Echocardiography guidelines for performing TE in adults in September 2021. So we have 3 guidelines which people can read and use as a guide.
No, the thing is, madam, good morning, madam.
Good morning, sir.
Yeah, nice to have you. The thing is, these are all the comprehensive TE examination is like learning ABC for reading and writing. So you
Yes.
should be, as you told, it is the views, angles, and basic things that are what we see, and what are the things we have to see or what we have to measure. If you
Yes.
learn the basic, the other things will be much easier.
Yes.
So today we have renowned our transesophageal echocardiography expert, we can say. He is a consultant in Cleveland Clinic, Abu Dhabi, our friend, our associate. He is now shifted since 1 year. Dr. Nagaraj, you can please start the lecture.
So thank you, sir. Thank you for those kind words. I've been a student in Jayadeva since past more than a decade, and it's an honor and privilege to have you as a moderator. And thank you, Rupa ma'am, for moderating this session. It's lovely to have you here, and thank you, Kanchi sir, for giving the opportunity to again share knowledge. I'm sharing the screen. Yeah, is my screen visible? Rajiv, is my screen visible?
Yeah, we can see it.
Okay, great. Okay, so as rightly pointed out by our esteemed faculty, that comprehensive TE examination needs a meticulous understanding of what we are doing in terms of multiplanar angle, in terms of rotation of the probe, and all these things. I would like to add on one more point, that we should be very clear about the anatomy to understand what we are seeing in the echocardiography. The more we are clear in the anatomy, you know at what depth we are seeing the structure, and what are we actually code for in the TE. So that is when the Narayana Vidyalaya has been instrumental in organizing this porcine wet labs to understand the anatomy and to better understand how to get the best view in a TE. So with that brief introduction, so I would like to, this is, see, the comprehensive team is more of a, what do you say, it's more of an interactive session. So what I try to do over here is, let us, I want all these, as the disclosure is basically all the guidelines which have been spoken about by Dr. Rupa Sreedhar. So this is, let's have a pre-test, let's have a brief 1 minute pre-test in which what we need to, what we are expecting from this session of TEA. So the first question, so everybody can put their answers in the chat box or write it on a paper so that you can evaluate yourself that what you take back from this. So the first question for you is, which is a view to obtain the mitral commissural regurgitation? Please write down your answer in a paper or put it in the chat box. Anything is fine. The second one is, which is a view to aid in retrograde cardioplegia cannulation? The third question is, which is a view to assess whether there is a presence of patent foramen ovale? The fourth, which is a view to assess the extent of aortic root dissection? The fifth question is view to assess the position of a balloon pump. The sixth is, what is a view to assess the regional wall motion abnormality if I want to see the entire anterior wall? And lastly, which is a view to assess the RVOT gradients? All right. So we got these questions correct. This is a pretest, just to analyze myself that how well this class has gone through the delegates. All right. So okay, let's dive in deep into the TE. First, before understanding any view, I'll just give you a brief introduction about the probe, how it looks like, and what are the measures what we need to take to set up the TE machine before actually getting the comprehensive views. So firstly, the probe, the disclosure is that these are all my previous, my Alumni Jayadeva Institute's videos. So I always preserve them to show. It's better to show the video. So before doing anything, the ECG leads has to be connected to the machine. And you always see that the ECG comes on your monitor. That's very, very important. The ECG has to come on the monitor. And the second thing is, you insert the probe. So before inserting the probe, once you set up the ECG, all this stuff, then you start inserting the probe. So inserting the probe is lubricating it very well. And then, there is a mouth gag. Some people use the mouth gag before inserting, but I usually use it after inserting. So you give a jaw thrust, and then I put the jelly inside the mouth as well. So adequate lubrication is very, very, and if you find any resistance, please do not insert it. Just use the laryngoscope to aid in insertion. Once you have inserted, then you can always put the mouth gag into the patient. And the controls in the TE probe, that is the shaft. So this is the shaft. You can see the marker there. And you have two rings there. One is the bigger ring and the smaller ring. The bigger ring is used for the retroflexion and the antiflexion. And the smaller ring, as demonstrated, it is used for the right flexion and the left side flexion, as you can see in the video how it's going on. So I'll play this video again for you so that, and what has been demonstrated now is the rotation of the probe, rotation to the right and rotation to the left. But in rotation of the probe, you have to rotate the shaft of the probe. You have to use the shaft of the probe to rotate it. So that is rotation to the right and rotation to the left. Okay, let's play this video for the. So this is very important to understand. See, the bigger one, as you go clockwise, it's anti-flexed. Anti-clockwise, it's retroflexed. And the smaller one is used again to the rightward rotation, rightward flexion rather, sorry, and the flexion towards the left. Yeah. So these are the various maneuvers what you can do in the probe. So briefly, you know about these indications and contraindications, which I'm not going to run through. You should absolutely know what are the indications and contraindications. Why are you doing your TE examination? Let's get on to the standard views. The standard views way back in 2013, there were 20 standard views which everybody has to do. And it's based on various depth positions of the TE probe. So as you can see in this picture, you have upper esophageal, mid-esophageal, transgastric, and deep transgastric. First, let's discuss about the standard views. Standard views are around 20 standard views. And you have, based on the depth, if your TE probe is in the upper esophageal, then you call it as an upper esophageal view. And if you advance the probe, what do you mean by advance? Advance is advancing the probe deep into the esophagus. If you advance the probe deep into the esophagus, then it's called as mid-esophageal. If you advance it into the stomach, then it's called as transgastric, and deep into the stomach, and then antiflexion to visualize the heart from below, it's called as deep transgastric. So based on this, and you also have the depth indicators, you have the depth markings in the TE probe to aid in what depth you are in. So upper esophageal, when you are in the upper esophagus and the mid esophagus, transgastric and deep transgastric views. So accordingly, have been classified. So let us first. This is the most important one, is the mid-esophageal views, because they are the ones which are most useful for us in our regular practice. So I call this as a mid-esophageal four-chamber view. I call this as a home screen. So whenever you have this home screen, whenever you get lost, then you come back to home. So it's called as a home screen for me. So the home screen is basically to attain all the four chambers of the heart. It's labeled left atrium, left ventricle, right atrium, and right ventricle. This is also called as a mid-esophageal four-chamber view. And you can see the probe position, which is very clear. Um, it's retro hard. That means to say it is behind the heart into the esophagus, and you're looking at the heart from the posterior part. So hence the tip of the probe, you say the tip of the probe is always pointing towards the posterior part of the heart, and the far field is always pointing towards the anterior part. So this is most important to understand, that you're looking the heart from the posterior part. So always the tip of the probe is at the posterior, and the far field is always in the anterior part. And the left-sided structures, so you see the left-sided structures, they're always on the right side of your screen. The left-sided structures as the green. So this green correlates to the same green sector, what you can see over here. The green is always in the green sector. So left-sided structures are on the right side of your TE sector, and the right-sided structures are on the left side of your TE sector. So these are the most important things what you can see here. And what do you want to analyze in a mid-esophageal four-chamber view? You see the four chambers of the heart very clearly, and you should also see that the probe or the heart is not foreshortened. What do you mean by foreshortened? Foreshortened in the sense that when you interrogate the heart, if this is the LV, when you interrogate the heart at the apex, till the apex, that means if the sector is exactly cutting like this, it means to say that you are involving the apex of the heart. That means the heart is not foreshortened. That means the left ventricle isn't foreshortened. If you have it in the middle, like in the mid cavitary left ventricle, that means the LV is foreshortened. So what is the maneuver, what you can do to avoid this foreshortened is that very clear. So if you're foreshortening over here, then you slightly advance the probe in, or some also do a small retroflexion to actually avoid foreshortening of the LV. So what are the structures? What you can see the left atrium, left ventricle, right atrium, right ventricle. You can see both the septums, that is interatrial and interventricular septum. You can see both the atrioventricular valves. So you know what are the applied things, what you can see in this. You can see the mitral valve anatomy. You can see the tricuspid valve anatomy. You can see the walls of the left ventricle. So here, the walls of the left ventricle, what you can see is... see, as you see over here, the walls of the left ventricle, the anterolateral wall, and which is close to the septum, is the inferoseptum. For me, I always have this mnemonic as Alice. So Alice is anterolateral and inferoseptal. So Alice, anterolateral and inferoseptal wall, and then you have the right ventricle. Okay, so this is a 3D image anyways. Let's talk about 2D majorly today. So from here, we go on to the second view, which is called as a mid-esophageal bicommissural view. So it's not four chamber. So mid-esophageal four chamber, it's not four chamber. So from the four chamber to the mid-esophageal mitral commissural view or a bicommissural view. How do you get this view? Okay. So to get this view, if you see the TE probe again, we have these two buttons over here. Okay, this button, one of this button is used to increase the multiplanar angle. What does this multiplanar angle do? This multiplanar angle steers the TE probe in the direction, steers the TE probe in a direction which is anti-clockwise. It see the first figure and see the second figure. So the multiplanar angle steers the TE probe at what degrees what you want. So here the multiplanar angle is moved from 30 to 60 degrees. So you steer the angle by pressing this button, and the multiplanar angle is moved. And this is a four chamber view. So you see this one. You see this one, which is on the left side of the screen. Yeah, that's at 0 degrees. And what happens over here, you see the multiplanar angle, which is at roughly around 50 degrees. So these are the rough angles. I mean, you get the you align or you optimize your image. There's no hard and fast rule that it has to be. It is just a guide for you to say that this is where you get the bicommissural or the mitral commissural view. So you see both the commissures of the mitral valve when you are at somewhere around 40 to 60 degrees. So here we got it at 53 degrees. This is a bicommissural view. It's also the mitral valve appears like a seagull. That means to say if I freeze this image, so I freeze this image, and then I see that this is the head of the seagull, and these are like the wings of the seagull. So this called as a seagull's view, in which the head represents the scallop of a mitral valve, anterior mitral valve, which is A2, and the right side of the screen, which is P1, and this is P3. So this is the P1 commissure, and this P3 commissure, all medial commissure, and this is the lateral commissure. So this is as represented over here. This is P1, A2, there's a left ventricle, and this P3, and there's a left atrium. So it's called as a seagull's view, or the mitral valve appears like a seagull. All right. So again, here again, it's you can see if you really dissect the mitral commissures pretty correctly, then you can get the two papillary muscles. So I see this view for one, the commissural mitral regurgitation. If you put a color Doppler across this mitral valve, then I can see the commissural regurgitation coming up. So that's the best view to get the mitral commissural regurgitation. And usually there is a button called as an X-plane. This is out of the scope of this. So when you put an X-plane over here, I put an X-plane over here, and then see the orthogonal view on the other side, to see the exact commissural regurgitation. So to be very simple, so this is the mitral commissural view from the mid-esophageal four-chamber view. Just increase the multiplanar angle to roughly around 40 to 60 degrees. The mitral valve bisects in the bicommissures, and you get the both commissures. There is a medial commissure and the lateral commissure. The medial commissure is on the right side, and the lateral commissure is on the lateral commissure is on the right. The lateral commissure is on the right side, and the medial commissure on the left side of the sector. And it's the P1 scallop and the P3 scallop, and A2 is the one which is interposing in between, which is like flying like a seagull. So there's a mitral commissural view. From there, you just have to increase the multiplanar angle. You see this animation. So it was roughly over here. It is roughly over here, and we have increased the angle to 90 degrees. So what do we get once we increase the angle to 90 degrees? So this is what we get. So we get the mid-esophageal two-chamber view. So you see that the right ventricle is out of the plane. This is the right ventricle over here. So this part is the right ventricle. It's out of the plane, and you're bisecting the left ventricle anterior-posteriorly. You're bisecting the left ventricle anterior-posteriorly to bisect the two anterior-posterior walls of the left ventricle. So very clearly demonstrated that the whole of the anterior wall, this is the whole of the anterior wall from the basal, mid, and the apex of the left ventricular anterior wall of the left ventricle is being clearly visualized. You can also very clearly quantify the regional wall motion abnormalities of the entire anterior wall and the entire inferior wall in this view. It bisects absolutely perpendicular in anterior-posterior direction of the left ventricle. Again, you can see the left atrium, part of the left atrium. And very importantly, if you slightly withdraw the probe, you can see the left atrial appendage also very clearly. It is like a finger-like projection. And to visualize your left atrial thrombus, you can use this view to get the Dopplers across the left atrial appendage for the thrombus potential. You can visualize this view. So this it's got a good application in terms of regional wall motion abnormalities of the entire anterior wall, the entire inferior wall ranging from basal, mid, and the apical sections of the left ventricle, and you have the anatomy of the left atrial appendage as well. In this view, this is called as a mid-esophageal two-chamber view, roughly got at an angle of 90 degrees. All right, so from 90 degrees, if I have to rotate the probe, very important, as I showed you in that video, rotating the probe is always rotating from the shaft, and see that the whole length of the TA probe is not curved, it's in a straight line. So that rotation actually is very clearly demonstrated at the tip. So when you rotate it towards the right side, your right-sided structures are well visualized. When you rotate your probe towards the left side, your left-sided structures are well visualized. From the left side, from the mid-esophageal two-chamber view, you start rotating your probe towards the right side. You get this nice image. See, it was bisected like this from the left atrium and the left ventricle. Now, what did I do? This TA probe, I started rotating it towards the right side. So the sector actually rotates towards the right side so that you bisect the two vena cava. So which is called as a bicaval view. So you have the SVC onto the right side and the IVC onto the left side. And interposing, you have the interatrial septum and left atrium very closer to the probe. Why it's closer to the probe? Because it's the most posterior structures. The left atrium closer to the probe and the right atrium is just away from the probe because it's the most anterior structure is the right atrium. And then you have an interposing interatrial septum, and the PFOs are usually visualized here. So usually the PFOs are visualized here, and the shunt, when you put a color Doppler at this part, at this sector, then you get the color Doppler signals coming from left to right normally, or if it's a reversal of the shunt, then it is from the right to left based on the BART, that is color which is towards the probe or away from the probe, red or blue. So this is to visualize the bicaval, which is you want to visualize the SVC, you want to visualize the IVC, you want the aid in diagnosing how the cannula is going when the surgeon is cannulating your SVC from the femoral. Then your guide wire, you need to visualize your guide wire coming from the IVC to the SVC, and the cannula also railroading from the IVC to the SVC. This is the best view. This is the most important view according to me, which tells more about your IVC pathology, SVC, your eustachian valve, the valve which guides the IVC. You can sometimes see the eustachian valve, and if it is more serpentine, then it's called as a Chiari network. And if it's a prominent IVC, then the surgeons might feel difficult when cannulating the IVC. Direct IVC cannulation might be difficult. So alert the surgeon that the eustachian valve is pretty prominent. So there are very, very important uses from this view. So if you slightly rotate it towards the left, then you might also see the coronary sinus coming from this place, or if you slightly go deeper, you can see the coronary sinus also coming from this place. So that is also used for your retrograde cannulation, in which you want to give a retrograde cardioplegia, cannulating the coronary sinus in terms when you have the aortic regurgitation, when you're not able to give an antegrade cardioplegia. So this is one of the very important views to see the PFOs, to see the interatrial septal shunts ranging from sinus venosus, also ASD, which can be seen when just withdrawing the probe. You can see most part of the SVC, so you can see the defects of the sinus venosus. You can see ostium secundum ASDs. You can see PFOs. All these from this view. So it's a very important view. So this is the 3D imaging of the bicaval view. So now rotate back to the rotator. Now you rotated to the right side to get the bicaval view. Rotate back to the left side. Again, you get the mid-esophageal, the two-chamber view. From the mid-esophageal two-chamber view, you just have to, you just have to rotate it towards the 120-degree slot. So once you get the 120-degree, then you get this beautiful long axis view, which is called as an LV long axis, in which the LV is dissected in the long axis, and then you have the opening of the LVOT as well, with the part of the aortic valve also in view. So this is called as almost like a 3-chamber view in a transthoracic. So this is a very good view. Most importantly, what you can see is the different walls of the left ventricle. As I told, in the 4-chamber view, you had Alice. Here it is the opposite. That means it is anteroseptal and the inferolateral. So initially we had Alice, that is anterolateral and inferoseptal. Now it is just the opposite because you have come to 120 degrees. So it is anteroseptal and inferolateral walls. So these are the two walls, that is anteroseptal wall and the inferolateral wall. So again, you can see the basal portion, mid portion, and the apical portion of the regional wall motion abnormalities. You can put a color Doppler across the mitral valve to visualize the mitral regurgitation. And most importantly, the scallops over here are A2 and P2. So scallops are A2. A2 is anterior, so it's more towards the aorta. So this scallop, which is on the left side, is a A2, and then you have the P2. And from here, from the long axis view, what you have to do to get the majority of the aorta is more superior. That means it's more above. So what do you got to do? You got to withdraw the probe because you want to see the structures which is more higher up. So you got to withdraw the probe. Once you withdraw the probe from the midesophageal LV long axis view, you get this view which is called as an aortic long axis view. Again, your root, the whole root is nothing but the LVOT, the aortic annulus, the sinotubular junction, the sinus, and the part of the ascending aorta can be very clearly visualized in this view. This is one of the very good views to obtain all your aortic root dimensions. You can see the flaps, which are very visualized. If there is a dissection, you can see the flaps. Majority of the flaps are seen at the sinotubular junction, and you can also see the right coronary artery also coming out from here. If you can maneuver the probe slightly, you can see whether the dissection flap is involving the right coronary artery or no. And you can put the color Doppler across the aortic valve to see what is the amount of aortic insufficiency, based on what is the amount of aortic insufficiency also. So this is a very good view to analyze your aortic root pathology and cusp pathology. When you see the aortic cusps, so very important, the most anterior cusp is the right coronary cusp. So the one which is anterior is the right coronary cusp. So this is the right coronary cusp. And the one which is closer to the probe is maybe the non-coronary cusp or the left coronary cusp based on the rotation. If you rotate more towards the left side, you get the left coronary cusp. Rotate more towards the right side, you get the right coronary cusp. So this is one of the best view to analyze your aortic root pathology and your dimensions. Okay, so you got to withdraw the probe. So next, from here on, from the aortic long axis, so from the aortic long axis, you start decreasing the angle. Now you had increased the angle, you start decreasing the angle. So decrease the angle in such a way that you come to 60 degrees. See, as you see around 60 degrees. When you come to 60 degrees, a beautiful, RVOT is opened up. So you have this view is called as an RV inflow and outflow. That means you get the tricuspid valve and you also get the pulmonary valve. And the aortic valve will always be in the short axis, and the left atrium is at the most near field, that is very close to the probe, and the RVOT very, very clearly visualized. From here, you cannot get the gradients of the RVOT. What you can get is a very beautiful view to visualize any resections in the RVOT. You can put a color Doppler across this RVOT to see whether there is any turbulence across. You can see whether your flows are laminar or turbulent, to get an idea whether what are the gradients across the RVOT. So this view is very clearly used to analyze the RVOT pathologies, RVOT anatomy, and you also see the free wall of the right ventricle over here. You can see the RVOT also. So it gives you, in a single view, it gives you the whole of the RV function. From the inflow, the body and the RVOT. So the crescentric shape RV is very clearly seen in this view, in which you can analyze your RV function, the free wall function, and you can also analyze the RVOT function along with the tricuspid and the pulmonary valve anatomy in terms of color Doppler as well. So it's obtained when you decrease angle from the aortic valve long axis view to from the long axis view to decrease angle to roughly around 60 degrees. You get this view. So this is how you get the RVOT in a three-dimensional. So this is from the aortic valve long axis, decrease angle to 60 degrees. You get the RV inflow flow. From the RV inflow flows further decrease down to around 20-30 degrees. You can get a clear Mercedes-Benz sign of the aortic valve. So decrease it to around 30 degrees. You get a clear Mercedes-Benz. All the three cusps of the aortic valve are very clearly demonstrated. What I've tried to do over here is decrease the sector length, or you can zoom across the aortic valve and then zoom it and see. So you can see the aortic valve leaflets very clearly. The aortic valve leaflets, very important, is that the one which is opposite to the interatrial septum is always the non-coronary cusp, and the one which is most anterior is the right coronary cusp, and the one which is on to the left side is the left coronary cusp. So this is the interatrial septum, and then the one which is closer or opposite to the is a non-coronary cusp, and this is the anterior most, so this is the right coronary and the left coronary. You advance and withdraw slightly, you withdraw slightly, then you can get the sinus, and you can also get the left main coronary artery arising from here, and the right coronary artery arising from here. So this is a very nice view to obtain, to see the aortic valve in the short axis view, to get your aortic valve orifices area through a planimetry, to see what commissures of the aortic valve have been calcified, what is the degree of calcification. The majority of the information of the aortic valve are obtained in that. So now we have analyzed the aorta. So you want to visualize your ascending aorta. So ascending aorta is more higher up. So what you got to do when you want to see any structure which is higher up, you withdraw the probe. When you want to see any structure which is lower down into the esophagus, you advance the probe. Now, if I have to see the ascending aorta, I got to withdraw the probe slightly from the aortic valve. So I withdraw the probe, slightly I withdraw the probe. I may get this view. To optimize the image, I may have to antiflex the probe using the bigger hose or the bigger wheel which is present in the shaft of the T probe. I need to clockwise rotate it to anti-flex the probe. Anti-flexion, you should be very, very careful. Don't do aggressive anti-flexion, just anti-flexion to optimize your image. And then you get this view in which you have the ascending aorta, you have the main pulmonary artery, you have the right pulmonary artery, and the left pulmonary artery is over here, which is obscured by the bronchus which is passing across. And you can also see your superior vena cava. You can see your catheter, your central venous catheter, already seen in the superior vena cava also. So now if you rotate the probe, you can see majority of your right pulmonary artery. Rotate the probe towards the right side, and rotate the probe towards the left side. You're lucky, you can see the bifurcation of the right and the left pulmonary artery as well. So you want to get the Dopplers of the main pulmonary artery. So this can be one of the views. Okay, and then you want to see any thrombus, pulmonary embolism of the right pulmonary artery, main pulmonary artery. You have this, and you want to see the dimensions of the ascending aorta, the calcification of the aorta. This is one of the views. You want to the SVC, and if you rotate to the right side, you can also see some sinus. You can see some sinus venosus or pulmonary veins also coming out from here. So you can see some sinus venosus ASDs also coming out from here. So this is one of the very good views to assess your ascending aortic pathology, if I have to say, and your pulmonary trunk and the branched pulmonary artery anatomy. So this is called as an ascending aortic short axis view. The same view, if you have an orthogonal that is 90-degree view, you get the long axis view like this. So you just have to rotate this multiplanar angle to 90 degrees. So then what actually bisects in the short axis bisects in the long axis view. So the short axis was the ascending aorta, this becomes in the long axis, and the right pulmonary artery, which was in the long axis, becomes the short axis. So this is again to have your dimensions of the ascending aorta, and you can see any dissection flaps which are most common in the ascending aorta. Okay, so this is the orthogonal view. From the ascending aorta, you want to go to descending aorta. So what do you go? You have to advance the probe slightly in, and then descending aorta is at the back. So descending aorta is at the back. So you got to rotate the probe. So you got to rotate the probe towards the, rotate the probe towards the right side, posteriorly, more posteriorly, rotate the probe towards the right side, towards one. You have to rotate the probe towards the right side. Then you get the posterior structure, which is very visualized, which is descending aorta, which is very close to the probe. So decrease the depth. Once you decrease the depth, your descending aorta will be very clearly seen. So decrease the depth and optimize your image to get the descending aorta. And once you cut the descending aorta in the long axis view, you get the descending aorta in the long axis as well in orthogonal, which is 90-degree view. That is descending aorta in the long axis view. Again, descending aorta, again, descending aortic measurements, and you can get the calcification. If you want to see any inter balloon pump, then you can see the balloon pump as well, and the calcification, you can grade the calcification in the descending aorta. So this is one of the views of these are all what we have in mid-esophageal views. And then let's go to upper esophageal before diving into transgastric. So mid-esophageal, upper esophageal. Okay, let's go to upper esophageal views. So upper esophageal are only two views. Again, from the descending aorta. Why I took up from mid-esophageal to upper esophageal is it's from the mid-esophageal descending aortic short axis view, you start withdrawing to get till the arch. That is upper esophageal. So till the arch. So you start withdrawing. The moment you see the aorta, which is from the round structure, it suddenly becomes oblong like this, So that is you are bisecting at the, see, as you come up, see, when you see this sector, you're right over here, the descending aorta. You're just withdrawing the probe so that you cut at the arch. So you get oblonged. So this is when you have an oblong. So you have this as a proximal arch, and this is the distal arch, and then you get this view. So always this is the distal arch, and this is the proximal arch, most important. So your cannula, when you have an aortic cannulation from the ascending aorta, sometimes you might see the cannula running in like this. You can see the cannula as well running in like this. So the descending aorta, from the descending aorta, we draw the probe, and then you can get this view. All right. So this is an orthogonal view. So when you see the orthogonal view, that is, you have to change the angle to 90 degrees. Here I have changed the angle to roughly around 60 degrees, but you change it to 90 degrees. Then this oblong portion, actually, I think I have a video. So this oblong portion becomes a circular portion. Okay, see that? You can see that oblong portion gets circular as I increase the multiplanar angle. So this is and you can also see in the next video, you can see the subclavian as well. So this is the subclavian artery, what you can see over here. So you know where the IABP balloon has to be placed. It has to be distal to the left subclavian artery. So your IABP balloon should never be seen in this view. So as you advance the probe from this view, you should able to see the IABP balloon. So that is, you can see the positioning of the IABP balloon very clearly from the aortic arch views. Either, short axis view, advance it inside, you should be able to see the IABP balloon. Okay. All right. So this is one of the cases what I did in Cleveland Clinic, in which there was, you can see in the upper image, you can see the aortic plaques over here, and you can see this cannula popping off, which is very close to the plaque. So I had to tell the surgeon, so there is a plaque over here. So the cannula was roughly over here. So I had to tell the surgeon to slightly advance the probe so that when you perfuse the aorta antegrade, so then you're sandblasting or whatever, you don't want this mobile plaque to rupture. So I advanced the probe in, and then the surgeon diligently advanced it into, and we had no stroke in this patient. This patient was very fine. So this is one of the very good view for a cardiac anesthetist to see what's really happening in the aortic arch, whether there are arch calcifications, where your cannula, you want the tip of a cannula to be positioned. Okay, let's get into transgastric views. Now you've finished about mid-esophageal, you've completed the upper esophageal. Let's get into transgastric. Transgastric is very clear. That is, you have the left ventricle, you're dissecting the left ventricle into pieces like this, So you are at the base, at the mid portion, and at the apex. So you're bisecting it at various levels of the left ventricle in the coronal sections. So here again, most important over here is you can see the mitral valve apparatus you advance the probe from the midesophageal 4-chamber view, advance it deep into. So advance it deep into and slightly anti-flex the probe. As you advance the probe, you might not see any structure. So slightly anti-flex the probe. You start seeing the structures of the left ventricle and the part of the right ventricle in the short axis view. So this called as transgastric basal short axis view. You have the mitral valve apparatus, as I told you very clearly, that this is the posteromedial commissure. This is the anterolateral commissure, and the one which is smaller, which is closer, is called as a posterior mitral leaflet. There's a posterior mitral leaflet, and this is the anterior mitral leaflet. And medial is 3, so it'll be like from here it is P3, P2, and P1. Okay, this is again subsequently it is A3, A2, and A1, and the walls very clearly demonstrated here. So as I told you, which is closer to the probe is always posterior, away from the probe is always anterior, so it becomes anterior here, and then you have the lateral segments over here, anterolateral, infralateral, and inferior, and the septal segments, that is introseptal and anteroseptal segments onto the left side of the sector. Most importantly over here is that you should have a good cut of the left ventricle to see the mitral valve apparatus. Then you can talk about the basal, the regional wall motion abnormalities of a subsegment regional wall motion abnormalities. And you can also put the color Doppler across the mitral valve to get your mitral regurgitation. So you go deep into, you cut like this, and then you anti-flex the probe to get the basal views. Okay, so the next view is you can either release the anti-flexion. So once you release the anti-flexion, you release the anti-flexion, then you cut it at the basal level, or you can advance the probe slightly in. So you get this view where you cut at the papillary muscle. So it's called as a mid-papillary view. It's called as transgastric mid-papillary short axis view. Again, the walls remain the same, but at the mid LV cavity level, and then you can get the regional wall motion abnormality. You can get the papillary muscle. You have a bifid papillary, HOCMs. You have Weger's papillary muscle anatomical changes. So you can get the papillary muscle dysfunction. So again, you can get your regional wall motion abnormalities. You can get your FACs, fractional area change of your left ventricle to get your ejection fractions, and all these. So these are for these are your mid papillary view, and from the I would say this is better visualized from the basal view. So transgastric 2-chamber view is at 0 degrees. Now from the transgastric basal short axis view, just increase the angle to around 90 degrees, which is orthogonal. You get this transgastric 2-chamber view. Okay, so 2-chamber view, very beautiful view. Again, this is a 2-chamber view, hence this becomes posterior wall, this becomes anterior wall, the entire anterior wall can be seen, posterior wall can be seen, and this is a very good view to visualize your subvalvular apparatus. And you can see a part of left atrial appendage very nicely, and you can get your subvalvular mitral anatomy, the chordae length, all things are very well visualized in the 2-chamber view. Just increase the multiplanar angle from this view to 120 degrees, you get a long axis view. Okay, this is again long axis view, and from this long axis view, you have to do a maneuver, which is rotate the probe towards your right side to visualize the right side structure. So then you get RV inflow view. This is the RV inflow view, which they say that you can analyze your tricuspid subvalvular apparatus and you can get your tricuspid anatomy. And this is the right atrial appendage over here. It's as similar to that of your transgastric LV 2-chamber view. The same structures what you can see. And the last view is the deep transgastric view. So advance your probe deep enough where you don't see any structures, and then you anti-flex the probe. Once you anti-flex deep enough, go from here. These are transgastric views. Advance it deep enough into the stomach, and then you anti-flex the probe to visualize the heart from the apex. So what is in the first image? This is the first image. See, the LV is foreshortened again. So probably from here, from this part, you're trying to visualize. So I went slightly advance the probe. In the second image, I advance the probe so that you can see the LV apex. This is the LV apex. So this is also it's the transgastric long axis view, in which you see the left atrium, you see the mitral valve, then you see the left ventricle, and the gradients across the aortic valve are very clearly seen. The gradient across the LVOT are very best obtained at this, because it's very parallel to the blood flow. When you put your Doppler signals are very parallel. So the gradients are best analyzed in these views. So these are in brief about the standard views. Quickly, another 5 minutes, I'll just take to get your modified views, which are roughly around 8 modified views. So I'll just quickly get how to get these modified views. And for the I think standard views are good. I'll just take another 5 minutes to get the modified. So from the 4-chamber view, this is a 4-chamber which I told you it's a home screen. From the 4-chamber view, so you want to get the LVOT in place. What do? You withdraw the probe, because it is slightly withdraw the probe more towards. So then if you withdraw the probe, the LVOT opens up. So this is called as a 5-chamber view. You can get your HOCMs where you see your septal hypertrophy and all these in this views. Okay, this is a 5-chamber view. And then you have mid-esophageal right pulmonary vein view. So this is obtained from this view. What is this view? This is called as a ascending aortic view. So when you have the ascending aortic view, from the ascending aortic view, as I told you before, so when you rotate the probe towards the right side, you can see the pulmonary vein coming from here. So this is the pulmonary vein coming. So this video should play. Yeah. So this is the pulmonary vein coming. You put the color Doppler and you can see the right pulmonary vein view. Mid-esophageal modified bicable. What do you mean by modified bicable? You want to see the, you want to get the Doppler across the tricuspid valve. You want to align your PW across the tricuspid valve. This is the view to go for. So this is called as a modified bicable view. So from the, what do you do from the mid-esophageal RV inflow view or aortic short axis view? You get the modified bicable by just by rotating the probe towards the right side. You get this view. Sometimes you might have to see, what I have done over here is the angle remains the same, but sometimes you might have to increase or decrease the angle to get this modified bicable view, which is called as a tricuspid valve view. You get the gradients across the tricuspid valve. You get a good tricuspid regurgitations also in this view. And this is a very important view when we do all this lung transplant. They ask us to analyze the flows across the pulmonary veins, the left and the right pulmonary veins. What I find it very easy is a single view is go to the aortic valve short axis view, rotate the probe towards the right side, get the right pulmonary vein, rotate the probe towards the left side, you get the left pulmonary veins. It's one view to go to for me. So it is rotate the probe towards the left side, you get the left pulmonary vein, rotate the probe towards the right side, it's a right pulmonary vein. I found it very easy from the aortic valve short axis view, mid-esophageal aortic valve short axis view. But for the right pulmonary vein, you might have to withdraw the probe slightly, but left pulmonary vein very clearly visualized. But for the right, you might have to withdraw the probe slightly and always put the color so that you don't lose your way. And the LA appendage view, as I told you, it's a 2-chamber view. You just have to withdraw slightly from the 2-chamber, you get the LA appendage view. And apical view, you have cut it at the papillary muscles. Just advance the probe slightly in, get the apical view. That is apical view. And this is the RV basal view, which is used to analyze your tricuspid valve anatomy, what is prolapsing, ATL, septal, or whatever. So from the always the tricuspid valve is more apical. So from the mid-papillary view, rotate the probe towards the right side. You can get this view, but it's slightly a difficult view because always the right ventricle is, if the right ventricle is dilated, this view is better observed. So this is a septal leaflet, and the one which is more posterior is the PTL, that is posterior tricuspid, and one bigger leaflet is called as an anterior tricuspid leaflet, ATL. And the last view, which I found is very, very important view, which is called as a transgastric RV inflow flow. There are two ways how you can get this view. The one way is how we got the transgastric RA inflow view or RV inflow view, transgastric RV inflow view. From this view, there is a other button which I told you for right and left flexion. You have to just use your right flexion to it. So just flex it to the right, then you get this view. It beautifully opens up the RVOT. This is the view where you can get the RVOT gradients. So it's absolutely parallel. It's not absolutely parallel because it cuts like this. So it's roughly you can get your RVOT gradients from this view. And I have also seen another view in which you have the RV basal view. So let me go to the RV basal view. Yeah, this is the RV basal view. From here, I rotate it towards the left side. I use the left side. Then again, I get it like this. This is at 0 degrees, and that is at sorry. Okay, so this is the last view of the day, I guess. Yeah. Okay, so this completes our all the views for today. So let's take the post test. I mean, it's labeled as previous. So anyways, let's take the post test. What is the view to obtain a mitral commissural regurgitation? What is the view to aid in retrograde cardioplegic cannulation? And what is the view to assess the patent foramen ovale? So what is view to assess the extent of aortic root dissection? And what's the view to assess the IABP position? So let's answer. I think everybody is in the chat box. I think, thank you. Live as you were to die tomorrow, and learn as you were to live forever. Thank you. And happy Republic Day. And this is my last slide. I thought it was interesting to show this. And this is not related to this. But anyways, this is pretty interesting to see this.
Nothing goes over. Okay, nothing crosses over. You see how that activation is?
Any guesses? What is this? Anyways, thank you. Over to the moderators. Prabhakar sir?
Yeah, Nagaraj, can you hear?
Yes, sir. Yes.
Yeah. Your presentation was, of course, extensive. Your talk was as usual. It was nice. Good questions. So, to feedback, you wanted to get feedback whether you have answered all these questions. Of
Yes,
course,
sir.
almost all the questions are answered.
Yeah.
So, one thing I want to know is the retrograde cannulation.
Yes, sir.
So for coronary sinus, you said bicaval adjusting or something.
Yes, sir.
Is there any other view where we can see that coronary sinus clearly to cannula?
Yes, sir. Yes, sir. So there are two more views which are added sir, of late, which are called as deep esophageal views, sir. So deep esophageal views, there are two more views which have been added, which I didn't want to talk about, which is exclusively for the coronary sinus. So it's nice that you got this point up. So there are two views which exclusively uses the coronary sinus. And what we do is, from the 4-chamber view, we just have to advance the probe inside, and then you can get the coronary sinus on the left side, on the right side of the screen.
The whole length you can see, so that it will be more.
You can see the whole of the catheter. Absolutely correct, sir.
Yeah. Okay. Anything, Rupa, madam?
Yeah, I liked your presentation.
Thank you, ma'am.
Did you mention that view at the lower end of esophagus where we can see the IVC and the hepatic vein?
Yeah, so, yeah, absolutely correct, ma'am. I mean, when we see the bicaval view, then decrease the angle and advance the probe inside, you see the majority of the liver, and then we can see the hepatic vein. But that is not mentioned in any of the views, but that's very useful for IVC cannulation and all these views.
Yeah. And which are the views which we use to measure the gradient and TOF after repair?
Gradient of SOPs. That RV inflow, transgastric RV inflow is a very, very good view to measure the gradients across the RVOT. And the mid-esophageal RV inflow views for the color interrogation, where we can see whether there is any turbulence, across the RVOT. So that will give you a fair bit of idea in the mid-esophageal view. And then you can go to transgastric. And then what I do is, I do it from the RV basal view. I rotate I flex the smaller wheel to the left side, and it opens up the RVOT, and just rotate the probe towards the right side. So the RVOT opens up, and that aligns the Doppler beam exactly parallel to the blood flow.
Yeah. This midesophageal ascending aorta short axis views where you can see the pulmonary artery lengthwise. That is a view where the gradient is almost equal to the gradient that you get using epicardial echo. So these two views give almost the best gradients.
The best, yes.
Yeah. And then, do you want to mention the basic 2D echo views which we use to acquire the 3D, the basic views which we use to acquire the 3D,
Yes.
3D images, just for looking at the mitral valve from the LS side and then from the opposite side. Yeah, from the LS side and from the LV side.
Perfect. So in 3D, as we see that we want to see an en-face view of a mitral valve, then we usually have this. What I do is I usually have this midesophageal LV long axis view, and from the LV, I can actually show that from the LV long axis view. What it's better that I show that. Yeah. So this is the LV long axis view, and then from there on, yeah, this is the one. Okay. All right. So this is the LV long axis view. So let's run this image. So this is the LV long axis view, what we have. So from the LV long axis view, there is a button called as 3D zoom. Let me go here.
Nothing is seen.
No?
No.
Oh, I think they're shared.
Time is up. Something
okay, time is up probably. So anyway, LV long axis view, you try to put the 3D zoom sector covering your mitral valve apparatus and a part of aortic valve apparatus to get the anatomy, and then you press the 3D zoom, and there is a button called as an elevation width and depth as well. So you orthogonal view, you check whether your mitral valve apparatus is clearly covered, and then press the 3D zoom button, and then use your pinball to elevate your mitral valve, and you can see from the left atrial side very clearly that and rotate towards a Z position anatomically, in which the aortic valve is positioned exactly at 12 o'clock position, which will align your mitral valve, anterior and posterior mitral valve smiling at you. So the anterior mitral valve is more anterior or towards the aorta, and the posterior mitral valve is towards the far field. So that is how we see the 3D zoom of the en-face mitral valve.
Can I make a comment, sir?
Please.
Srinivas.
Sir, please, sir.
Yeah, something about the pulmonary veins I'd like to comment. Usually, the right pulmonary vein we can see in 4-chamber view as well as in the modified bicable by extending the probe to one sector angle to 120 degree and turning probe to right. So in both these we can get a right upper pulmonary vein parallel to the probe. So usually it is parallel to the float of the transducer. The lower right pulmonary vein is usually obliquely placed. It may not be exactly parallel to the direction of the, so that you can get mainly at a 4-chamber view, and also from the bicable view, that is at 120 degree. If you slightly reduce the sector angle, then you can see the right lower pulmonary vein.
Yes.
The right middle pulmonary vein usually joins the right upper pulmonary vein. So all these are very important for the PAPVC, partial autonomous pulmonary vein aspiration. For the left-sided pulmonary veins, among the 28 views, one view is from this 120 degree right upper pulmonary vein. If you just move across entire LA and go to the left side, you see the pulmonary veins, left pulmonary veins in reverse Y position. So there you can interrogate the pulmonary veins very clearly. So at 120 also you can get, or as you mentioned, at aortic valve short axis, if you turn to left, you also can get. So the lower pulmonary vein especially, you get at little higher sector angle at something between 60, 70 to about 120 to 130. So that is one thing. Second thing, one small clue is that upper esophageal aortic short axis view. You showed that when you see pulmonary valve and pulmonary artery, along with the short axis view of aorta, the vessel which corresponds to that is usually the carotid. You mentioned about the subclavian artery during position of but if you see the position of the carotid, that usually corresponds when you see the pulmonary artery and pulmonary valve in the same view. So that is one addition I have to tell. And one more thing is the views of the sides of the heart have been changed in the 2013 guideline. Like for example, in fourth chamber, you get the right on the left hand side, and left on the right hand side. When you increase sector angle to 60 degree, on the left hand side, what you see is a medial, and on the right hand side is a lateral. Then 90 degree, they have mentioned inferior and superior. And at 120 degree, they have mentioned posterior and anterior. That is from left hand to right hand. That is some new things. And whenever possible, we always use the modified biplane view in all the cases. Now, most of the machines have 2D. Even though we don't have 3D, they install the biplane views usually. So, your 13 guidelines are mentioned to see the basic views in biplane views. That will help us in better assessment because you see two views in the same cardiac cycle. And one technical thing, usually we insert a TE probe before they position the patient and before they drape the patient, because sometimes that may be difficult. There may be difficulty in inserting the probe once they extend the neck and put something under the shoulder, like a bolster under the shoulder. Sometimes there may be difficulty in inserting TE probe. So usually prefer to insert a TE probe before they actually give position to the patient. That is usually our protocol.
Thank you.
I agree.
Thank you so much for
Thank you
that
so much.
excellent talk, Nagaraj.
Thank you, sir.
And I would like
Thank
to
you.
thank Dr. Prabhakar, Dr. Rupa, Srinivas, and others who are present here for contributions.
Thank you,
As
sir.
the time is up, and we would like to thank everyone for participating, and we look forward to having you once again on the next Sunday for a different topic. And I request the sponsor, ClearNet, to play the announcement of the Act TV program to be held in August this year. Thank you so much and good luck.
Thank you so much, sir. Thank you,
you.
Sreedhar, sir, for the
Thank you.
comments. Thank you, Prabhakar, sir. Thank you, Rupa, ma'am. Thank you, everybody. Thank you.
Thank you so much to all the dignitaries present here. Clarity is really glad to have all this brilliant people together in the session today, and I hope you all had a seamless experience. So, with everyone's permission, I'm concluding the session in here for today and looking forward to host you again. Thank you so much, everyone, and have a great day.